Hello everyone, you're watching sqadia.com and now we are on the treatment of the rheumatoid arthritis. In this section, we'll be going through how to make the diagnosis, how to make the differentials, what else we need to rule out when we are suspecting rheumatoid arthritis in a patient, and what are the principles of medical and surgical treatment. Coming to the making of diagnosis. Presence of a bilateral symmetrical polyarthritis involving the proximal joints of the hand or feet, persisting for at least 6 weeks. There are presence of subcutaneous nodules on examination and X-ray showing signs of periarticular erosions, and positive test for RF or anti-CCP. This all may be leading towards rheumatoid arthritis. The pathognomic is the involvement of small joints of hand, the history of wage pain, swelling, and stiffness, then which persists over the more than 6 weeks, presence of subcutaneous nodules, especially the rheumatoid nodules, and then in the lab positive RF or anti-CCP. This most likely means the patient is having rheumatoid arthritis. Coming to the differentials, what else we should be thinking when we are dealing with rheumatoid arthritis? This includes seronegative inflammatory polyarthritis, example SLE and psoriatic arthritis, as they also have RF positive in them. Ankylosing spondylitis. Sometimes the patient really comes with low back pain and hip pain, and we are not sure that with this ankylosis which is happening at the sacroiliac joint is either due to ankylosing spondylitis or it is due to rheumatoid arthritis. So we need to properly differentiate these kind of patients from RA from AS at this stage. Then other includes the Rite syndrome and reactive arthritis. As I just told you that there's a large group of disorders such as inflammatory rheumatic disorders. Ankylosing spondylitis, rheumatoid arthritis, Rite reactive arthritis, Rite syndrome are all part of that inflammatory rheumatic disorders. Then polyarticular gout. This could be because if gout really involves the first metatarsal, but this may involve hand as well. And if it's involving hand and there is swelling in nodule, it not necessarily means the patient has got rheumatoid arthritis. There may be presence of gout as well. Then these bony erosions and articular damage could be due to calcium pyrophosphate deposition disease, especially in the knee. And once we have arthritis with the knee, we need to rule out whether this was due to the rheumatoid arthritis or CPPT. Others include autoimmune disorders such as sarcoidosis, especially in the chronic sarcoidosis. There may be some degree of autoimmune specific arthritis and pulmonary fibrosis, which may mimic end stage rheumatoid arthritis. Then Lyme disease is also one of the differential because it's a tick-borne disease, but eventually this antibodies which are produced against this offending organism lead to increased destruction of the joints. As a result, there is arthralgias, myalgias, which is very much typical feature of rheumatoid arthritis as well. So patient can have Lyme disease, which is very different from the rheumatoid arthritis, but may present may mimic the symptoms of rheumatoid arthritis. Then there is an example of viral arthritis, which is resulting in increased joint edema, swelling, and painful joints, but patient may not be having RA rather viral arthritis. Other include polymyalgia rheumatica and lastly osteoarthritis. Usually osteoarthritis occurs at the age of 70s and 80s in females especially, but sometimes in early onset, if it's not a common garden osteoarthritis, in early onset this may be occurring at 50s. So we have usually at 40s and 50s, this is the time which is also age for start of the symptoms of rheumatoid arthritis. So sometimes you have to differentiate whether it's the rheumatoid or it's the osteoarthritis. Coming to now to the treatment, then it's basically, as I just told you, it's a multidisciplinary approach. There are multiple people involved in caring for the rheumatic patient. There is a rheumatologist, then there's an orthopedic surgeon, then there's a physiotherapist, then there's an occupational therapist, then there's an orthotist and a social worker. Now, if you see it over here, out of the 6, the 4 are the physiotherapist, occupational therapist, and orthotist. they have a lot of role in management, because sometimes the deformity is so debilitating, then patient may need occupational change as well. Then that patient may need some kind of an orthotic device so that he or she can be ambulate, she can ambulate and carry out his or her activities of daily living. Then there is role of physiotherapy so that the joints remain supple. There's already stiffness going on, and if the physiotherapy will not occur, this will further deteriorate to increased stiffness. Now, we need to be very clear what are the factors which ascertain prognosis. When if a patient comes to you before the initiation of treatment, we need to be certain that how this disease will progress after the initiation of the treatment. Although it's not clear cut that you can say that okay, this disease will, this is how it will progress, but then there are certain factors which determine its progresses, and these include female sex. If a patient is female, there are multiple joints involvement at the time of presentation. There is a high ESR and CRP, that is, patient is in active phase of disease. There's positive RF and anti-CCP. A younger age of presentation, let's say 30s or 40s or before 30, patient is obese with a high BMI. There is a history of smoking as well, and there are presence of erosions, that is articular erosions in the joints on X-ray. These are all the factors which lead to poor prognosis. So if a patient has multiple number of poor prognostic factors, we need to counsel the patient that okay, the disease is severe, and yes, we are starting the medications, but it will take some time to at least halt this progress of the disease, or at least to reduce it. Now, coming to the medical treatment, this includes steroids. Initially, oral doses of 30 mg prednisolone may be started, but if we are giving prednisolone through intramuscular routes, we can give about to 120 mg. But as you know, the steroids are highly effective to reduce inflammation, but steroids are kind of notorious for their side effects, which actually they bring with the patient. So we need to remember that yes, we have to give steroid to these patients, but they should be tapered off as early as possible so that the body is saved from the harmful effects of steroids. Now, then coming to those drugs which actually modify the progression and the natural history of rheumatoid arthritis. These includes the disease modifying anti-rheumatic drugs, or DMARDs, which includes a methotrexate, which is given at the dose of 10 to 25 milligram per week, initially alone or in combination with sulfasalazine and hydroxychloroquine. The other drugs which can be given are leflunomide, and which is usually if methotrexate is not tolerated due to its side effects. Historically, it was gold and penicillamine was used a lot, but nowadays they have been abandoned due to high amount of side effects, especially of gold. Now, DMARDs can be divided into two types: non-biologic and biologic. Now, non-biologic includes these drugs such as hydroxychloroquine, leflunomide, methotrexate, minocycline, sulfasalazine. Now, biologically, drugs include another class which is either TNF inhibitors or anti-TNF. Now, non-TNF include betasept, rituximab, and tocilizumab, while anti-TNF inhibitors include adalimumab, certolizumab, intaracept, golimumab, and ifiximab. Now, along with steroids and DMARDs, we need to start off non-steroidal anti-inflammatory drugs as well, because there will be inflammation, there will be swelling, there will be pain. So NSAIDs also have a role in decreasing the symptoms of inflammation and decreasing the degree of pain. Control of pain, stiffness, and maintaining muscle tone and joint mobility, for that NSAID is indicated. Then steroid injections can also be used, but usually in the large joints such as hip and knee, we can give steroid injection, but not in all joints, especially in the small joints of hand and finger. Steroid injection is usually not a feasible option, but they can be a very good option in large joints. Coming to the biological therapies, include those non-TNF and anti-TNF inhibitors. Now, these include TNF inhibitors, which is infliximab, antaracept, golimumab, and certolizumab, and adalimumab, While inhibitors of T cell co-stimulation includes abatacept, and the interleukin 6 is inhibitor is tocilizumab, and B cell depleting therapies include rituximab. These all are non-T inhibitors which inhibit T cell co-stimulation, interleukin 6 and B cell therapies which include abatacept, tocilizumab and rituximab. Now, role of physiotherapy in occupational therapy, sometimes as we know that there is increased amount of stiffness in the joints, so physiotherapy is needed so that the joints remain supple and deformity, despite deformity, patient is able to carry out his or her activities of daily living. Which actually the role of physiotherapist and occupational therapist is prevention and splinting orthotic devices, delaying the march of events, encouraging activities. Now, if end stage has reached and there's marked deformity, as you can appreciate on the right side, if you see it, there's such high degree of hallux valgus, there are clawing of the toes, and this with this deformity, a patient will not be able to walk properly. So in that case, if it's now a late stage has arrived and there is end-stage arthritis and deformity, then probably the surgical therapy is an option at this point. And then this time, the orthopedic surgeon has a role that it comes into play. That includes soft tissue procedures in the early stages such as synovectomy and tendon repair. If there is end-stage rheumatoid arthritis of hip or knee joint, there may be TCAR, total hip replacement may be needed. Osteotomy for joint stabilization in case of small joints of hand and toes. In the later stages, once the ankylosis are set in and the joints have become so grossly destructed that there is not a lot of things which can be done, then options include orthodesis, osteotomies and orthoplasty, eventually replacement. Now this is a classical diagram. A is actually showing a classical rheumatoid hand, ulnar deviation and radial and volar displacement of the wrist with rheumatoid nodules as well present on the knuckles. And if you see on the x-rays, the most affected joints are metacarpophalangeal joint, and there's some degree of involvement of proximal and distal interphalangeal joints. The surgery was done. There was knuckle replacements of all the 5 fingers was done, as you can appreciate in this, and some degree of ulnar deviation has been corrected and knuckle replacements has been done. Now, every disease has its complications. Certain disease has complication due to its natural progression, and then once intervention has been done, it further sometimes produces more complications. Well, complications in case of rheumatoid arthritis includes fixed deformities, muscle weakness, infection and amyloidosis, especially amyloidosis, beta amyloid protein collection in intestine and kidneys, which may even lead to kidney failure. Spinal cord compression, especially due to C1, C2 instability, or called as implanto-exit instability, and systemic vasculitis, which may produce the gangrene of the limb or distal parts and leading to amputations. Thank you very much. Keep watching sqadia.com.